Yes.
Yes.
Now
Yeah.
I've been unmuted, so I'm all ready to go. With the permission of all the seniors over here, I'll not waste much time and I'll straight away go to the slide session.
Sir, 1 second. I'm
Yeah,
stopping my
okay.
sharing.
Okay.
Right. You can take over, sir.
Okay. So as we have all been highlighting from yesterday, and we all understand that we are in tough times, but there are brighter sides to things. And this image is from our own campus at Ames, and you can see the blue sky. With that positive note, I just want to share this video as well. Keep your audio on and just see what we want to achieve to have freedom. And in this time of lockdown, I think it's imperative that we realize what it really means to have freedom. With that small video, I'll move on to the topic per se. So today's topic given to me is transthoracic and transesophageal assessment for planning of ASD device closure. And I think I owe a lot to all of people who have taught me and those who continue to influence me intellectually. And with that, I'll start by saying that no battle was ever won according to plan, but no battle was ever won without one. I think this is very, very important, and it cannot be more relevant in any other case than in case of ASD, where all the planning occurs outside the lab, and what happens in the lab is just one part of it, as was highlighted yesterday time and again. And that is very much true in ASD, because by imaging we can sort out a lot of issues which are related to ASD device closure, including the site and the size of the defect, the status of the rims and the adjacent structures. And it also helps us in deciding what kind of imaging assistance we need during device closure, whether it needs to be a transesophageal assistance or we can do under transthoracic echocardiographic assistance. Now, before I can venture into that, although Dr. Radha has elegantly described the anatomy of IAS yesterday, I would like to take a bit of it so that we can again connect ourselves to the anatomy which is relevant to device closures and the ASD in secundum location. Now, this is what we call as fossa ovalis region. And as you would see, this is zoomed up picture. If you can relate with me, this is the superior vena cava. This area is the inferior vena cava. This is the area of tendon of Todaro. This is the area of coronary sinus, and here lies the tricuspid valve. This area is the muscular rim of the inferior septum. So this whole part is the true septum. This area, if there is a deficiency, it is better called as fossa ovalis defect, or commonly we know it as secundum defect. This defect, if it occurs, this is actually a muscular defect, and some people believe that this should be called as vestibular defect because it arises from the vestibular aspect of the lower part of the septum. Now, this image shows the similar fossa ovalis defect, but which is extending towards the inferior vena cava, and the inferior rim is possibly deficient. And we all know, those who have been doing ASD device closure and those who are learning about it, they all know that these defects come in different shapes and sizes. And that is why it is very, very important that we understand what we are dealing with before we want to close it. Now, this is a simplified image produced from CT, and this is AP projection, which shows that this is the aorta, this is the non-coronary sinus, this is the tendon of Todaro again, this is the coronary sinus, this is the defect in the fossa ovalis region, this is the SVC, and IVC lies somewhere here. As you would know, and you would appreciate here, the SVC lies slightly anterior compared to IVC, and all these details are important when we are imaging any case, especially if it is actual septal defect. And these are the rims when we talk about this is a very simplified cartoon, and I don't think this matches with the AP projection. This rather matches a little more with the RAO projection, and I'll come to slide details of that. And since I have been given, I think 25 minutes, I'll try and show some of the my own understanding of atrial septal defect, which will possibly improve the imaging understanding. And as yesterday Dr. Radha was mentioning that this defect has to be defined not just in terms of its superior inferior location or anterior posterior location, it has to be said in terms of what are the adjacent structures and what are the relations with the adjacent structures. That's what makes our job easier once we know all those structures very well and how far they are lying from each other. Now, this is the again a CT image. This is the atrial septal defect, which is an oblong defect. In this direction, once you see it is the longest, and in this it is the shortest. Again, to reiterate the same, this is the non-coronary sinus and this is the fold, and that is why this part of the septum is not said it as the true septum, and the true septum lies only in this part of the interatrial space. Now, I just wanted to take 2-3 minutes on showing one CT, how we just see this. So this is one CT. I'm taking some liberty here, deviating from this, but I think it's important that we go ahead like this. So this is one case, adult patient with an ASD here. And as you would appreciate, there is right atrial enlargement, right ventricular enlargement, but the anatomy doesn't become as clear as we see in the 3D. So this is the 3D reconstruction, and I'll just straight away focus onto the ASD part of it without wasting much time over there. And as we try and do that so-called virtual dissection, you will just see how it unfolds and shows up the rims. This is the same patient whose image I was showing just some time back. And here you see that for all those who are having grid view videos on the screen, please remove it, because I want to show all the parts of the screen so that you can relate to me when I am moving the video. So if you can see the screen, the rightmost corner shows the cube, and it shows how this ASD will look like in AP projection. And again, as we can see here, this AP projection gives us all the details. So this is the aorta, this is the SVC, this is the ASD, this is the coronary sinus and tendon of Todaro. And here lies the IVC.
Saurabh,
Yes,
Saurabh, we are seeing a fixed frame of your PowerPoint presentation. I hope you are doing some reformatting on your computer with Osirix or some other.
Okay, I think I'll share that screen. Okay, just a minute, sir. Just a minute. Just give me a moment, sir.
Yeah, for all the participants, so far what we were seeing was Saurabh's PowerPoint.
Okay, I'm sorry, I did not realize that, since I haven't done it before on Zoom. So I think, yeah, now you are seeing the CT reconstruction.
Yes, perfect.
Yeah. So I think without wasting much time, I'll just say that I have recreated a volume rendered image here from a patient with ASD who is an adult. And now I'm trying to show how we will see in AP projection. Now, these all things are important, although not for echo, but it gives a 3D perspective to our understanding. And once we understand it, any imaging modality becomes quite easy to understand. Now, this is the AP projection that would be seen by this cube on the right top corner. And as you would realize that this is the non-coronary cusp of the aortic sinus. This is the tendon of Todaro, coronary sinus again, and this is the ASD in the secundum location. Now, this is the SVC rim, but now we are not sure about the aortic rim. So, as we all know, the atrial septum is best profiled in the RAO view. Once we see that, now we are seeing the atrial septum in its entirety, and this is the rim which is retro-aortic. And this is how we can see rims. Now, this is the IVC, and I was mentioning time back, the IVC lies slightly posterior and off axis to the SVC, and they are not in the same plane. Now, that is important because this actually helps in moving our TE probe when we are actually doing the TE. Now, you see, this is the place of IVC, while this is the plane of SVC. They are not in the same angle. If you draw a line like this, they are not in the same angle. That is why I will tell later why it is not seen in the bicaval view when we try to look at the IVC rim. And similarly, if you want to see the left atrial aspect of that defect, then we can see similarly by rotating it, and we can see the left atrial aspect of the defect. Now, this was just to orient you to the three-dimensional anatomy of ASD. And I thought that from a patient, it would be much better than rather than using some of the histopathological specimen, which doesn't reflect the real clinical anatomy. Now I'll go back to the slides, and I'll continue from there. Okay, my slides are seen, Dr. Shiva?
Yes, now we have started seeing your slides.
Yes, yes. So now, as we have realized that this is the AP, this is the RAO plane, and that is where we are seeing this retro-aortic rim very well. Now, before going further, we need to know which ASD is an ideal ASD for device closure. A defect which is central, which has a good rims, ideally which has a length more than 5 millimeters all around. Better if the rims are sturdy. Expected device should be LA disc, not more than septal length, and no impingement of the adjacent structures. And I think everybody sitting here would be knowing, but just to reiterate, this is the RA disc, this is the waist, and this is the LA disc. LA disc is the largest dimension, which is 7 millimeters more than the waist. So this should be accommodated by our total septal length. Now, but the problem is that the creator never knew that we would be putting devices in here. So he did not create all these defects centrally located with perfect sizing. And as we can see from this study of 190 patients, only 46 patients, which is 24%, had central defect. All others had some other issues related to that. And that is why it is imperative that we understand what kind of defect we are dealing with before we can actually close the defect with the device. Now, this is the concept of total septal length. I think most of you who are listening to me already are aware about it, but I could see some of the faces who are still under early phase of their training. I think this is what we mean when we talk about total septal length. And as I said, because the largest dimension has to be accommodated within this, they should not be beyond total septal length. However, there is a small study of adult patients where people saw that even if the LA disc is encroaching upon to adjacent areas, follow-up studies, MRI studies have shown that there is no problems, in, at least in terms of pulmonary venous inflow. So it's not such a big problem, especially if it is slight encroachment into pulmonary valve, but so it is reaching apparatus. Now, echo is the most easily available echo modality, and this is the screening imaging modality in all. I just go steps how we assess. I think some of the images are taken from some of the seniors who are sitting over here. So this is the EP projection, and we are seeing in the apical 4 chamber. And as we all know, that echo is cross-sectional imaging. This is the line of plane in which we are. And this is how we will be cutting the atrial septum, and that's how we will be seeing the images. This is apical 4 chamber. It's not inverted as you would normally do, because quite a few people see this way, and I think for better understanding, I have just kept it like this. Now here you can see that there is a well-defined defect with the rims both towards the mitral side and on to the opposite side. And if you go back into the image which I showed, you can see that this is the area which is being profiled when we are seeing the rim opposite to the mitral area. Now similarly, when we are seeing parasternal short axis, this is the plane which is something like what we see in 0 degrees on TE, but would be slightly different. And this is how we see this. Here, it shows up the better relationship with the right-sided pulmonary veins. Depending upon whether there is a superior tilt or an inferior tilt, we can see whether it is a superior pulmonary vein or an inferior pulmonary vein. This is sagittal subcostal. Again, the line is drawn here. And as I was mentioning here, SVC and IVC are both in not the same plane. That is why you cannot see both the rims in the same plane. That is why you have to rotate it. And that is how you will make judgment whether IVC rim is present or not. And this is elegantly shown in this image. If you keep sweeping from right to left, here the septum is intact in relation to the pulmonary vein. Here at the level of SVC, again, it is intact. And I will show some of the images. So like in this case, the septum is intact to the rightmost. Then there is a defect when the SVC is seen. And then there is a defect is again seen in further sweep on the left side. And we keep on sweeping. And this is the area in the region of aorta. Now, so this is what I think Dr. Radha was mentioning yesterday about dynamic imaging. There is no point in just taking one slice of the heart and thinking that this is a suitable defect, because while we sweep, we will understand more about the defect and we will not miss the largest dimension, which is very, very crucial when we are planning device closure in any such patient. Now, one more thing which I wanted to highlight here is eyes doesn't see what mind doesn't know. And I think quite a few of you would have recognized by now what I'm showing, but those who have not, I'm just explaining it here. This is apical 4-chamber view. And when this is the crux, just above the crux, before you open up the aortic valve, and there is a tube-like structure which is crossing from right to the left. And this is the location of retroaortic circumflex. And this is the relative contraindication to device closure in ASD, because there have been reports of coronary compression, except in those cases where there is a retroaortic rim, which is more than 5 millimeters, which makes the device away from this circumflex and makes the chances of coronary compression much less. So we need to be aware, and this is such a simple way to assess this retroaortic coronary on transthoracic echo. So Dr. Shiva, can I move or?
Yeah, perfect. Perfect.
Okay. So now coming to TE, before we go on to septal defect assessment, we must realize what do we mean by different views in TE, because without understanding that we can't move forward. Now this image on the left panel shows the position of the transesophageal probe. And this is the upper esophageal, this is the mid esophageal, this is the transgastric, and this is the deep transgastric. When we assess ASD, we are playing around in these two areas, because as you would realize that once we push our probe inside, we are looking at the inferior part of the septum. When we are pulling upwards, we are looking at the superior part of the septum. And this area actually shows the multiplanar aspect of the TE probe. As you would know that this is the 0 degrees, this is the 45 degrees, this is the 90 degrees, and this is 135 degrees. And just to make ourselves oriented, we can also turn it to right and left to see the right and left aspect of the septum, which is so very important when we evaluate the septal defect for device closure. Now again, the same image, I will just superimpose this TE probe onto it, and then you will realize what I'm meaning when we talk about this is the 0 degrees, and you would see that this is the mitral plane, and this is the posterior lateral opposite to that. This is the 45 degrees. So we see the retroaortic and the inferior posterior area in the posterior aspect, bicaval view, and you will realize why we don't see the IVC. I'm emphasizing it again and again because that is very important. We should not mistake eustachian valve for IVC whenever we are imaging this. And 135 degrees or 120 degrees, how it will show the coronary sinus area is quite clear from this cartoon, which is superimposed in the CT image. Now I'll give you a glimpse of what we see when we do 0 to 10 degrees. Now, this is not a slice imaging. Also, although it is a cross-sectional imaging, we draw different lines of plane. We push our probe inside and outside to scan it at multiple levels. And that is why we scan the defect in its totality. And that is how we see that this is the area which is in the relation to the mitral, and this would be opposite to that. Now, these are the different areas where if we see, then we will realize what is the superior-inferior extent of the defect. Now, similarly, on 45 degrees, it is not a single line. It is a multiple lines. Lines can be many more. Just for the representation sake, I have taken only 5 lines to show you how 45 degrees will scan the area which is behind aorta going up to the IVC. And as you would realize, the IVC opens up in this direction. That is why parasternal short axis area in the transthoracic echo, sometimes we can make our judgment about IVC rim, as also was mentioned by Dr. Radha yesterday in his talk. Now, this is the way we look at, this is not fixed 40 degrees, it can be 40 to 50 degrees, and minor variation can be there because of the change in orientation of the heart and different issues. Again, the same 90 degrees, we do this. And as I was mentioning again, here, since the planes are different, here we need little more of right and left rotation so that we can see the SVC and IVC in its proper manner, rather than missing out or mistakenly thinking some other tissue as IVC rim, because that can actually be the patient. See that this is the SVC and this is the, unfortunately our T screen only shows the angle. It doesn't tell you about the right and the left rotation because there is no reference to which it will measure. And that happens by the, that is performed by the operator, and that is why it is not shown here. But I'm sure when we are seeing the IVC rim, this has been rotated towards right to make it appear better. Now, this view is not very well written in the literature. Most of the people must be using it, but I find it myself very useful whenever we are trying to see oblong or unusually eccentric defects, and that's how it will help. This will actually, this will delineate this area much better than any other view. And again, as we can see that this area is also better defined in this. And sometimes this may be the plane in which we are having the largest dimension. And sometimes we may be wondering why our device slipped despite proper sizing. And this view may be having the key of some of those embolizations. So at least in our practice, we routinely do these 4 views. Now, this is about retroflexion. As we know, the ultrasound characteristics, closer it is to the structure, poorer is the definition of that structure. So once the IVC is very close to esophagus, so since the probe is very much close to it, we may not be seeing it. Once you do a retroflexion, it makes the probe away from the IVC, and you start seeing the IVC rim. This may be important in some of those cases where we have decided to attempt device closure despite having small rim. When there is a large rim, for the beginners, I don't think this is very important, because with such a rim, this may not be a great idea to start your cases. But yes, once you have been experienced with some of the cases, then you can make some of the cases which you initially felt not suitable turning into suitable once you do such imaging. Now, so basic aim of our TE imaging is to scan this whole septum into 360 degrees using different planes. And I think I have emphasized very clearly, this is 0 degrees in the red line, this is 45 degrees in the yellow line, 90 degrees in blue line, and green line tells you about 110 to 120 degrees. And I think it's quite obvious. Once we have a central defect like this, there is no problem. Whichever way you do, even if you take one scan line, it doesn't matter. But it becomes important if your defect is lying like this. Then you can imagine if you have only single line of intersection, then you might miss your longest dimensions, and you might have trouble even after choosing a apparently a suitable size device. Now, if the defect is like this, then the problems are much more. If there is a defect, some additional defect lying somewhere here, then again, it becomes important that we scan the IAS in its entirety rather than just believing or relying on only few views. So the TE assessment also is important to assess the flimsy rims. If they are flimsy, we might decide to upsize, excluding those flimsy areas of the limb. Additional defects, to assess their size and location and suitability to cover with a single defect, or to devise a strategy for an additional device if you want to use. It is also very crucial in patients with IAS aneurysm, because in those cases, it's quite difficult to size the defect properly. Complex ASDs, when we have more than one deficient rims, or the rim is, or there is malalignment of the septum. Now, this is just the summary of this. So 0 degrees, 45 degrees, 90 degrees, and 120 degrees shows different areas of the rim. And this is how I mentally think about, and I think everybody else must be doing the same, that we put 0 degrees, 45 degrees, 90 degrees, 120 degrees, and then we just put a line over there and we think about what would be the size of the defect. And that's how maybe we are better placed in deciding the device size. Now, some cases, it's quite difficult, even if it looks easy here that there are two defects, we can, tear with a balloon or something like this. In such cases, 3D may be more useful. I don't think we are having enough time, and I'm not expert in doing a 3D here, so I'll be not discussing it any further. Now, although my topic was just before the device closure, but I'm just taking 2-3 minutes here to show the utility while using TE when we are doing device. As you can see, we can decide why this device is getting prolapse. Is it the size issue, or is it the orientation issue, or is it the technical issue about with the device, or the sheath orientation and different issues related to that. After the device deployment, again, we can see all the rims. And this is just one example where we are taking 0 to 180 degrees, and in the one go, we are able to see different rims caught and their suitable, whether the defect has been successfully closed. Now, this is one, I just wanted to emphasize, this is my personal thought that for the beginners, this gives quite a bit of heart-skipping movement for all of us who start in the lab. But this kind of movements are expected because of the type of device which we have and the attachment of the cable. And as you would see here, some of these orientations become much better once we release these devices. And once we see a few of them under TE, it gives a lot of assurance that as to what will happen once we'll release the device. This is very important, as I said, in the larger devices, because we need a kind of certainty before we are releasing the device. Now, this is again, I wanted to just emphasize one last point here. This is from Circulation 2008. Again, a TE image in 0 degrees. This shows the retro-aortic circumflex here. And actually, this device was taken out because they documented that there is coronary ischemia after putting a device, and they had to take out the device. But be mindful, all what we think is not always true. And we experienced such a thing in one case where you would see that there is a tube-like structure just behind the aorta. And I'll make it clear in this frozen frame that once we place the device, we start, I was there who was doing the TE, and I started realizing there is something happening over here. And I did not understand initially. We ended up doing a coronary angiogram, which was normal. So actually what happened was, some of you would have visited AIMS before, you would have realized that it's usually not so bright and blue. Thank you so much.
Thanks a lot, Saurabh. It was a wonderful demonstration of the principles behind echocardiographic imaging and a lot of emphasis on transesophageal echo imaging. I'm sharing a lot of questions that came up in the chat box. Couple of things that happened where the audio was not perfect in the initial few days. I think it is a teething trouble for all the people who are using Zoom, WebEx, and all. Over a period of time, I think we will come out of it. And similarly, a lot of people were asking for slide sharing. I'm sure the PCSI will take some efforts. Now, coming to the specific 6 questions that came up during the chat box discussions. Number 1 was septal length. One of the person, I could not identify his name because of the phone's name was coming up. He was talking about the septal length being a controversial situation. In fact, Saurabh clearly told that the principles of assessing the septal length is to ensure that the left atrial disc does not far exceed the septal length. I think this goes by the simple logics and principle. It really holds good. I think it is a good idea to follow that. But Saurabh himself stated the subtle controversy in this area, wherein a group of patients who have undergone a device closure with the left atrial disc that is marginally larger than the septal length. However, on later MRI imaging have not been found. I think Dr. Saurabh has already dealt with it. The second question that came up, there was a good slide that was shown by Dr. Saurabh on Kodner's, one of the assessment of different types of ASDs with what are all the deficient margins. As everybody understands, most common deficient margin is anterior or superior. And fortunately, the posterior and inferior margin deficiencies were only in about 8 to 9%. So I was surprised to see that there are not any patients who are having an antero-inferior mitral margin deficiency in that particular slide that you are showing. So it speaks to say that the vestibular spine and the dorsal mesenteric protrusion that contributes for the mitral margin, which is actually considered to be one of the thick margins, is possibly not a common deficient area at all. Like I was looking at this particular slide, you see that there are people who are having deficient superior, inferior, but it's not very common to have, like the inferior anterior rim that you have mentioned is just seen in about 1%. It's a minority. That probably was explained by the vestibular spine and the dorsal mesenteric protrusion, dorsal mesenchymal protrusion that you are mentioning. Is that correct?
Yes, sir. It's a kind of very uncommon situation, and usually it is a small defect. So many a times, even if we may be seeing it, we might be just leaving it because it's a small defect. But most of the time, whatever images I have seen are from the specimens, and I haven't come across a transesophageal echo of that. So I'm sure what you are saying is right, sir. So and more so because it's a small.
We don't come across too many patients who are having a deficient mitral margin, and that being a feature for rejecting a patient out of the interventional group.
I won't agree to that completely, sir, because some of the cases we have seen that where the mitral rim is very small, where there is possibly deficiency of the fossa ovalis floor as well as the part of that vestibular thing. So I think the combination is much more common than isolated deficiency of the vestibular region.
Yeah, probably.
I think Bharat was agreeing to me.
Rarer type, I think. Another question that has come up from Arun Bableshwar is, there was one of your video that was showing a device prolapse, and he was asking about why it prolapsed and which rim was absent. What we could see from that image was that the retroaortic rim was deficient. But any updates on that particular?
Yeah. So actually, I did not want to take too much of time on that. I thought that the next speakers will take on that. But this case particularly, I wanted to show there was no problem with the device size. There was the problem with the orientation in which we were coming from the left atrium. There was a absent aortic rim, but we placed the same device in the next attempt. So this was prolapsing from the aortic region, which is not uncommon. Despite having correct size of the device, it's mostly related to the orientation, the way the LA disc, the superior aspect of the LA disc is coming, and that is beautifully seen on TE. Once we see few of those, then become wiser how to handle that situation, how to manipulate that. So I wanted to emphasize that.
Actually, the orientation of the catheter sheath assembly from the inferior vena cava is never completely perpendicular to the plane of the intraatrial septum, and so in larger ASDs, it is quite common, especially when they are having deficient margins. Yet another question that came up was the CT scans initially when you are starting to show a lot of good images on the furrows or osserics and how you are analyzing. The CT's spatial resolution of a thin and flimsy atrial septal rim. Now, we all know that we make a lot of over-assessment of atrial septal defects when we do a transthoracic echocardiogram, especially in a patient with suboptimal echocardiographic windows. We feel that the ASDs are quite large, and subsequently when we do a transesophageal echo, we identify a lot of thinner margins, and the size of the defect sometimes becoming smaller than what we anticipated on conventional thoracic echocardiography, because a higher spatial resolution is provided by the transesophageal echo. We all know that the CT scan spatial resolution should be far more inferior, especially when it is thin and flimsy margins, and more so if it is a very mobile atrial septum, as in the case of an atrial septal aneurysm. Your thoughts about it?
Yeah, CT is much inferior, as you just suggested, sir. Thin rims are not well seen on CT. Rather, there can be artifactual dropouts in the septum in the area of fossa ovalis, even if it is actually intact in the patient. It is also related to the way we acquire CT scans, because we can't reduce the blood coming from SVC and IVC, which is unopecified, and the rapidity with which the CT takes. So the temporal resolution also plays a role there, because it's a thinner structure. If you can imagine, if the structure is static and you take a snapshot, you have the best chances of picking it, but it's all moving. So I think as of now, CT is not good for thinner rims and aneurysmal septum. I won't go for it for the sizing of the ASD. I was just showing to make all of us understand about the relations of ASD.
All these three-dimensional models, they increase the perspective and the understanding of the operator rather than providing a perfect spatial resolution. And
Yes.
a simple transesophageal or in smaller patients, a transthoracic echocardiogram today stands the best spatial resolution for assessing an ASD. Now, again, there was a brief step back. I'm going back to the septal length. Dr. Krishnakumar from Cochin wants to share some of his thought processes about atrial septal length. Satya, can you unmute Dr. Krishnakumar from Cochin?
Yeah, I've been unmuted for a while. I think so the question is, we need to be honest about septal length. Most of us, I have stopped measuring it for a very long time, last probably 1,000 plus ASDs. And we use other methods of making sure that we don't oversize the device. But the septal length as an entity is so vague and so non-standardized. I don't think it's worth wasting our time in actually getting that number and coming up with something arbitrary. Instead, making sure that your device will stay away from vital structures, and using that is is a much better way. Avoiding the mitral valve rim in particular, making sure your device will not actually come in the way of the mitral valve. That may be a more appropriate way, not ridiculously oversizing in patients who are small. These are the methods of looking at it. If you see, Bharat has a paper very recently in quite small babies, less than 10 kilos, and he's shown successfully having closed a number of, almost a sizable number of those patients with large defects without actually trying to respect the so-called septal length. So I'm not sure of its value.
True. The consensus probably is that septal length being, number one, a very, very dynamic measurement with every cardiac translational movement, the septal length is going to be varying depending on which phase of the cardiac cycle. And number two, the amount of remodeling of the atria that might happen after we close the atrial septal defect with the length. Exactly, the atrial septal length should not exceed the left atrial disc probably does not hold good, because we do lack a good understanding about the atrial septal length. But the net message will be, you start having an element of caution if the size of the defect that you are going to choose with its left atrial margin is far exceeding the septal length, and keep very closely introspecting the procedure as it progresses on. The next question that came up, Saurabh, was about the retroflexion of the transesophageal echocardiographic probe and what the advantages that it is going to give to you. As you nicely mentioned, that if your imaging plane is extremely close to the transesophageal echo probe's footprint, then the images are going to be suboptimal, and retroflexing actually increases the distance, thereby bringing the focus onto the echo zoom. One more additional aspect here will be, as the esophagus keeps going down the esophagus moves well away from the inferior vena cava, and so there is going to be a sizable number of significantly larger adults who, despite all the efforts, may not show up their inferior margin far clearly because of the sheer anatomical separation between the inferior vena cava, which is moving far more rightward, and the esophagus, which is moving far more leftward. The one more question that came up was the sudden reorientation of the device that happens when during the release sequence, especially of a very large device or in a very small child. These are probably being taken care of by certain new release mechanisms from Seraflex or the Figula devices and all.
Shiva.
One of the question that has come up by one of the person is, if the IVC margin is going to be a little bit tougher, can transthoracic echo be definitely a better imaging tool for an IVC margin than transesophageal echo? I think Dr. Saurabh clearly showed the advantages of transthoracic echocardiogram in inferior margin in smaller patients whenever it is possible, and that is the best method. However, in an adult, probably we may have to go for transesophageal. Dr. Saurabh?
Yeah, regarding this second question first, sometimes when the device is in place and the IVC rim is thin, after putting the device, it becomes quite a difficult thing to image whether the rim is inside that or not. At least we at AIMS feel that sometimes in those scenarios, even if the windows are not great, it gives better perspective if we are using transthoracic subcostal window, because it somehow gives that separation of the inferior aspect of the device better than what we see on TE. And that's probably related to some of the imaging issues. Regarding that adult with the large esophagus and getting away from it, I think as cardiologists, we are not, most of us, I'm taking a little liberty of underestimating some of us, that most of us are more tuned to those mid-esophageal or maybe slightly lower esophageal views. We are not so tuned to the upper or shallow deep gastric views. So if we make ourselves comfortable in that, so I think we'll get better views in terms of inferior vena cava, and more so if we learn to rotate our probe right and left. Because I was, when I started doing this imaging, I wasn't so sure about why IVC is so difficult to see. One of the reasons is that it doesn't lie in the same plane, and that can be easily taken care of by if we are rotating it towards right. And that rotation is quite a bit.
Maybe, Shiva, some of the questions can be answered by the subsequent speakers during the talk. And I request other speakers also to reduce the talk and spend more time to answer the questions. So that will give more interactive session. Shiva, you can moderate and you can go ahead, whatever you want.
Nageshwar, is there a potential for one question, or if you don't have time, I'll move on?
You can ask Shiva, you can probably moderate. You can ask us one question.
Actually, I am continuously seeing the questions, and I am just refashioning the questions. There was a question about how to address an oval defect where there is a maximum dimension and where there is a minimum dimension. I think probably this is technical, because probably
there are few studies, but I think it will be better dealt in
probably the next speaker is going to tell about when to choose the maximum defect size and when to choose the average of the maximum and minimum. The next question was about the role of 3D transesophageal echocardiography in assessing the atrial septal defect. It definitely gives a very, very nice like the 3D perspective. That